Dr. Muhammad Taufik Ismail. He's from Indonesia.
Thank you, Dr. Khanna. Thank you, the honored panelists, and also thank you for the gentlemen, and also Professor Khanna for inviting me. I would like to present about dissection causing worsening of acute limb ischemia in profile. Patient come to the hospital with acute left leg pain because of the inadequate INR level at the time, and also patient stopped drugs for 3 days. This patient also have history of anthrostomy 1 month ago, and also asymptomatic right leg artery occlusion at the time, and also infected endocarditis at the time. We can see from the echocardiography this vegetation of in the mitral valve. The patient was diagnosed by infected endocarditis. And 1 month ago, this is the ECG of this patient. We can see as the elevation of the anterior lip, and we can see here that there was total occlusion of the left anterior descendant of the artery, and then we perform balloon angioplasty and thrombus aspiration. Actually, before the patient was performed coronary intervention, we got difficulties when we puncture of the right femoral artery. So we think that maybe this is an occlusion of this vessel. So we decided to puncture at the contralateral on the left femoral artery, and we can see here that total occlusion of the right iliac artery for 1 month ago. But the patient was asymptomatic, and we just performed thrombus aspiration, and we got some several thrombus here, and then we also examined the pathologic anatomy of the thrombus, and we just only thrombus and no sign of infection. And now, 1 month later, after first procedure, patient now left leg is on pain, and we can see from the arteriography that there is total occlusion of the left common femoral artery. But we can see still here the distal of SSP still flow from the collateral. And the other operator was performed angioplasty using pilot 115 and also backup microcatheter fine cross. But we can see that this dissection here. At the time, the operator still try to open to find the true lumen, but you can see that the dissection become larger. And then he decided to stop the procedure. And the unity from this problem is because of the patient has recurrent thrombosis in young female. The patient also have infected endocarditis and also iatrogenic dissection. And what will we do? And 2 days later, actually the leg become warm. Yeah, there's still collateral flow supplied well by collateral, but the pain was persisting. So we reattempt or intervention of the femoral artery. You can see here that I try to use glide wire knuckle to achieve true lumen, but that's not the same. Yeah, dissection here. Even though I try to make knuckle wire in the proximal part of the common femoral artery, but still we cannot cross true lumen. After trying, and we still lost, also loss of profunda. Here, profunda was lost, and then the collateral also was lost. And start and also long capillary fill time. I try to puncture in the pedal artery using ultrasound guided. And then I try to another puncture in the distal of the SFA, but I can't see I cannot find the artery, and we just got pain because from the ultrasound guided, we cannot see clearly in the flow of the artery. Then vascular surgeon to make popliteal cut here, like here. And then we also call the anesthesiologist to turn the patient to prone position to make the vascular access from the popliteal cut down. After patient access from the popliteal, and then we insert the glide wire and mechanical here, constantly cross the lesion through lumen easily. And then we decided to perform balloon dilatation by 120 millimeters. The draw time from distal to the proximal of SS. After balloon dilatation, I cannot still see the distal flow of the artery. That's why we perform angiojet using Omni catheter several times. And then I turn back to the position. And after angiojet catheter, yeah, the flow was good until the distal. We can do still any residual thrombus in the SFA and also in the popliteal. Because I cannot reach the catheter angiojet cross the popliteal cut down because of the lumen is narrow because of the ligation. But we can see here that the flow was good, and at the time the leg was become better, redness, and also make warm. Yeah, after first hours, we all happy. Team, this is the vascular surgeon, and 1 month later at the follow-up, the patient can stand and walk properly. The conclusion is, yeah, the target should be achieved and treat underlying disease. Like for the patient, this is of the thrombosis in this patient is vasculitis secondary to the infective endocarditis. And the second take-home message, early Rutherford 1, I think we have to consider, is it we should revascularize or just base medical treatment? Because we can see from the guideline ESPS 2020, there is no place again in early Rutherford A to do revascularization. But in this patient, because of the etiology is infective endocarditis, so we choose to perform revascularization to reduce the risk of aneurysm of the artery for the next time, if any thrombosis or any septic emboli left in the artery. And I think we have to avoid dissection using proper device, using like knuckle glide wire, even the thrombus is soft or not chronic total occlusion to avoid dissection. And tackling loss of flow or collateral using multiple access can be done, like pedal access or femoral access, or if so we can call our surgeon. Thank you. This is my recommendation.
Congratulations again. I thought that was very clear. Are there any questions from the panel?
Me, Dr. Reid, I want to ask to the presenter, Dr. Taufik. First is congratulations, you have accomplished the case. It's a very good result. But I want to know this: the patient is a young girl, only 12 years old, with infective endocarditis. But other than infective endocarditis, what do you think about the like Takayasu arthritis? Because it's the young girls with the multiple vascular defects. You treatment this is before the how long the distance the days between the coroner you do the coronary angioplasty with the second vascular, on the acute limb ischemic. What do you think? What on the short times these young girls have to go underwent the treatment?
Dr. Rin, my senior in good evening and thank you for your question. Of course we still can think that the lesion of vasculitis large artery can also involve this patient, like you mentioned before. But at the time, we know that the patient also have occlusion of the coronary artery and also the iliac artery at the time. This patient also have established of the diagnosis of the infective endocarditis. So we think simply first of the etiology of infective endocarditis. So and this also a patient also involving on this medium and also large artery, and this patient also have infective endocarditis. So we think that this patient is caused by infective endocarditis, Dr. Rini. And 1 month later, the patient got thrombosis again. This patient has had acute limb ischemia, and so maybe this is due to of the infective endocarditis. Because we also check echocardiography 1 month later, and we can see from the mitral valve, the vegetation was gone.
Okay. So this is the acute limb ischemia, or the lesion is solely caused by the emboli. What you choose for the prevention for the next anticoagulant you give to this young girl, because this is very young, no?
Yeah. Thank you. Actually, if this patient still have infective endocarditis, I think we have to give warfarin for long life. But if we can still assume that this patient still assume that patient has no again of the infective endocarditis, we can stop it. But we know that even though there is no vegetation of the echo evaluation, I think we still have to give warfarin, also antibiotic for infective endocarditis. Because we see that from the guideline that we have to give antibiotic for more than 20 years.
Okay. Thank you, Dr. Lid. The times.
Good. Any other questions from the panel?
So we can move on to
Dr. Kadro is from Dubai, a cardiologist in Dubai, is the next presentation then, isn't it?
yeah, that's right.